Our next speaker is Larry Wissow. Larry Wissow was initially trained in pediatrics. After residency, he completed a fellowship in clinical epidemiology and served for 7 years as the co-chair of the Child Advocacy Committee at Johns Hopkins Hospital. He then went back to training in adult and child psychiatry, and since that time has been a faculty member at the Johns Hopkins Hospital, School of Public Health. His research and clinical work centers on the integration of children's mental health and primary care. This afternoon, he's going to be speaking on toxic stress, practical approaches to supporting children and families, and after he finishes speaking, then we'll be doing the question and answer session. Please welcome Dr. Larry Wissow.
Well, thank you. Thank you all for the chance to be here. As I was coming in, I was realizing how many mentors and colleagues and friends are in the audience, and how what a debt I owe to all of you. There are a couple of people actually that I thought I wanted to sort of give a shout out to. Dr. Jane Foy actually, through her graciousness in letting a late abstract come into a Peds 21 meeting several years ago, let a good friend and colleague, Anna Gadomski, give a talk about common factors, whatever that was, and that's been a huge boost to our work. The AAP staff has been amazing, and Linda Paul, who's running around with little yellow things, has probably done more to move my work ahead than almost anybody. And we've been really lucky to be funded by SAMHSA and the National Child Traumatic Stress Network to be working on a set of learning collaboratives for the last few years, and on integrating mental health and primary care. And several of the folks who've been involved in that are here and milling around, and we've learned a tremendous amount from you, and I can't thank you enough. So I'm going to say, first of all, that I have nothing to disclose other than what I just did. And my overall goals are really to talk about how we can be safe and therapeutic clinicians for kids and families exposed to trauma, and think about skills for communicating safely, helping people maintain a sense of dignity and control while they're visiting with us, create environments that where problem solving can take place, and build partnerships with families over the long term. And certainly most of these things have been touched on by our prior speakers, so I'm kind of the wrap up and all that stands between you and the pithy questions that you want to ask. So I'll try to go through this pretty quickly. The big things that I really want to cover are things, RJ mentioned this, creating a therapeutic office environment, building positive relationships, which comes so much from how you do it as much as what you do, building engagement with families, considering the environment, the context in which people live, psychoeducation, and building regulatory capacity. And this is just my version of everybody else's little bubble slide. This is from Tom Insel, formerly the head of NIMH, and the point is really just that sort of big middle blob where it says secondary processing, integrated circuits, social or non-social, the idea that exposure to trauma changes the way we process the inputs that we receive, and it changes our behavior, and so we want to be conscious of that. Another set of sort of overall thoughts, this is really hard stuff. When people behave in ways that seem maladaptive in front of us, how can we be curious rather than annoyed? As RJ said, this version is take your own pulse rather than put on your own oxygen mask. Why is this annoying? Why is it pushing my buttons? But overall, being confident that even in the most complex situations, we can be clear and informative, we can be genuinely interested in helping, we can find things with which to empathize and connect, and we can certainly commit to be with people over the long term. So thinking about how to build a therapeutic environment in our offices, again, this has been touched on, but I don't think it can be underlined as being too much. people's impressions of us, of our offices, really start with the first contact, with the first call on the telephone, even maybe the first piece of paper they see. The image of the relationship that we want them to have with us is built up from their observations of how the staff works with each other. Patients, and we've all been patients, so we value staff who pinch hit for each other, who troubleshoot and solve problems, who speed things up when they're needed, and most of all, who can realize when things have changed, when we've come back, but something's not right this time, and we need a little bit different treatment. What about our facility communicates calm, respect, openness, confidentiality, competence, and friendliness? We've all got stuff in our offices, but there are ways that we can do this that are more effective than others. And how do we actually organize ourselves to be able to give the kind of compassionate care that we want? One of the huge, cultural differences that comes up between mental health providers and primary care providers is how we sort of handle interruptions and distractions and multitasking. And when we sit down and work with families who are about to tell us something difficult, or we're in the middle of a discussion that's difficult, being interrupted can really just completely derail that process. So are there ways that we can have appointment slots that offer some protection from distractions? Can we have huddles or some way of getting together as a team at the beginning of a clinic session to anticipate which families are going to need longer visits, who's going to need more complex time, and how can we protect ourselves from that? We've talked about awareness of families who may be hungry or homeless. And we have lots of drills in our offices for CPR. We know where the crash cart is, but are we prepared for the youth who gets up and decides to bolt out of the room, finding a calm place for agitated people, knowing what the local crisis response resources are? So being prepared for these sorts of things. There's a lot that's been mentioned about how we can try to engage people when they first come in and talk to us. Getting everybody's priorities is important, stating your commitment to working overtime. And most of all, along with that statement of commitment, really not being too premature about bringing up referrals or even bringing in someone else into the office. The people that we deal with who've been traumatized are very sensitive to rejection, to abandonment, to the idea that somehow or other you can't handle what they're about to tell you or what they've already told you, and even the hint that you might be trying to sort of duck out can be very off-putting. The hardest thing probably in all of this is how not to look rushed. We've all tried to practice this at various times. It's clearly a game. It does involve a little bit of sort of, touching the door frame on the way in and saying, I will take 2 deep breaths, I will sit down, I will actually be present, for the next, 10 or 15 minutes. But trying not to look rushed is really important. Thinking a lot about transparency. I think that many of the speakers today have mentioned over and over how the negative experiences that people have had in the past make them really sort of both hypervigilant, wary about what might be happening, what could be the consequences of what they do, and just also in some ways feeling vulnerable and unprepared depending upon what comes up that they haven't been able to be fully aware of. So don't expect that families know the drill, and especially don't expect that children know the drill of what's going to happen in a visit. So how can you signpost where you're going, why you're asking questions, explore people's potential fears or assumptions about why you're asking things or what might be the outcome of their giving you an answer. Be very upfront about confidentiality. What am I going to be keeping confidential? What might not be? And this is really a paradox. We've all been sort of taught about asking open-ended questions, and that the best, and I'm as guilty of it as anybody, about leading off with open-ended, nice questions rather than being very sort of closed-ended. But open-ended questions can be extremely anxiety-provoking for people who don't know why you're asking them and are afraid that they might give the wrong answer. So sometimes you need to lead up to them with a few sort of closed-ended, banal sorts of things, or even just a few things that kind of set out the stage for where you're going, and then you can ask that open-ended question, is there anything else? Another real big one is ask permission, and ask it a lot over and over again. And in fact, one way of, I think, thinking about asking for permission is that you haven't done it enough until somebody says, why are you asking me for that all the time? Of course you can. So ask permission to ask questions, ask permission to sum up what you're thinking, ask permission to give advice, and certainly ask permission about what kind of follow-up people would be willing to take part in. We've talked a lot about context during the day today, so being curious about context and empathizing with it, and obviously this includes parents as well as kids. Another thing that's really hard is to try to model suspension of judgment. I mean, one of the things that I was taught as a pediatrician was to be a cheerleader, to be very positive, but sometimes when we are too far that way or too far another way, it creates a space in which people think everything's got to be good or everything's got to be bad. Sometimes being neutral about things is the best. There are no villains, there are no heroes in this game. There are just people who work really hard. Try to learn how to acknowledge and empathize with people's feelings. You don't have to endorse what people are thinking about, but you can definitely say, I hear you. One of the hardest things, I think, about working with any of us when we're under stress is that we start to do stuff that is considered annoying to other people. And trying to figure out how to deal with that is not always easy. So one way to think about it is to say that if people are responding to you in ways that seem maladaptive, that this could be conditioned or defensive behavior. Especially for adolescents, it's sometimes the shutdown or the I don't care. Sometimes it's provocative or very titillating kinds of talk that's really sort of meant to get you off guard yourself. A lot of times it's just rejection of the kinds of advice that you want to give, or refusal to stay on task, just changing the subject all the time. So don't take the bait for this sort of stuff. Try to name the emotion, tell people, here's what I think is going on. You look excited, you look worried. Try to say something empathetic and have a plan up your sleeve. So one of the, I think the best metaphors for this is the rodeo metaphor. You're just really trying to sort of stay in the ring. Keep your expectations modest. Resist the urge to retaliate, because sometimes this stuff is really annoying and you just want to say, stop it. Don't do that. Consider whether there could be some gender or racial or ethnic issues going on that are feeding into this, and maybe just gently try to explore why it's going on. But the big deal is to ride it out and realize that if you can try to establish a relationship, this stuff will eventually fade away once people feel comfortable. I think RJ was talking a lot about just what we would call universal sorts of interventions. What are some things that you can do that really just are potentially going to help almost anybody and that are within your capabilities of doing? So the first is, what are the sort of modifiable stresses that a family might be experiencing right now? Are there short-term demands that can be deferred? Are there chronic demands that can be reduced? And this idea that people know about these things, that you can turn to them for ideas is really important. Had the picture of the hornet's nest before. Another metaphor that often comes up when talking with families with complicated problems is the idea of the double drowning. I don't know if they still teach this in water safety instructor stuff, but I remember having it when I was an adolescent. It's the idea that if someone is drowning, you don't want to jump in with them because they'll just grab you and then the two of you go down. And the whole idea of working with many families with complex problems is that they exude hopelessness, and they invoke that hopelessness in us frequently. But what I try to remember is a couple of different things. I mean, one, that families have strengths. Every family has strengths. And secondly, something that one of my psychiatry supervisors once said, which is that if you're coming up with all the answers, then you're not making the patient work hard enough. So turning this around and saying to people, well, what are the things that you think you might be able to change? What are the things that might just make stuff just one little bit better that you could take off the plate that might help you to cope with this better? People almost always have those ideas, and you can troubleshoot those with them and encourage them to try them. We've talked about concrete needs. It's very hard to deal with other sorts of stresses when you're homeless or when you don't have food. We often forget that caregivers themselves are part of extended families, and we have to understand who they might have to answer to. We talked about immediate threats to safety. What are supports and who supports the supporters? Sometimes there are lots of other people that need to be brought into the room, literally or figuratively, and just by even starting to identify those folks, you're helping people work on their own social connectedness. So I'm a child psychiatrist in addition to being a pediatrician, and one of the questions that often comes up is, we see these families and people seem to have obvious mental health issues, what should I do about them? I think one thing that's really nice about mental health issues is that fortunately they're often not big-time emergencies. There are emergencies that you can identify, and if they are, you can try to get help for them right away. But most of the time what people need is simply to know that this is something that's, possible for them to get help with, and that they can think about the ways in which they'd like to get help for it. So if somebody does have symptoms of depression, somebody does have symptoms of anxiety, maybe even they seem like they might have some thought disorder, one of the things that you can say is, well, I notice this. Do you notice this? And could we talk about it at some point? Would this be okay? And is now an okay time, or is later an okay time? And when the time comes that people are comfortable with it, you can say, well, these are in fact common problems. That's why I noticed it. There are a lot of options for treatment. I know some of them. We might need to find some others. And can we work together to sort of figure out how you'd like to address this? And often that's a way to get around, I think, something that maybe it was RJ, also mentioned, that half the people that we try to send on to other services don't get there. One of the reasons is because they're not ready to get there. So trying to engage people around the issue and then saying, when you're ready, you can do it, can be more effective. Another big problem that comes up with families and kids who've experienced complex trauma is the issue with cognitive comorbidities. So we've mentioned that before, and sometimes the arrows go in both directions, but learning problems, especially in kids who've experienced trauma, are very common complications, and it goes in many different ways. So one is that these contribute to kids' sense of shame, stress, and isolation because they're not doing well in school. They don't understand what's going on around them, and they find themselves increasingly isolated. Sometimes they behave badly, and sometimes that bad behavior is a result of the stress. Sometimes it's to cover up what it is that they don't actually understand. The other problem that we run into is that bad behavior is often an excuse that schools use for not investigating why the kids are having these problems. So a really huge piece, I think, of dealing with kids who've experienced trauma is trying to figure out how you can do good in-office assessments to figure out who are the kids who have these sorts of cognitive issues and trying to move them toward diagnosis and services. There's the single biggest piece of psychotherapeutic stuff that one can do other than the empathetic listening and bonding with people that we've been talking about is psychoeducation, just helping people to understand what's going on with them, to say that there's a name for it and that there is something that can ultimately be done about it. I think that you've probably gotten plenty of hints from the people who have spoken before me today about some of the things that you might want to say and not say. Often at the beginning, trying to provide some explanation, but not necessarily too much, is a good thing because you really don't know how people are going to take it. It would be interesting in the question and answer session to talk about what people's experiences are with trying to sort of show brain diagrams or talk about toxic stress as a toxicity versus something that has affected the way you think and act, but could in fact be reversed or changed, because it's very hard to know how people are going to sort of take these sorts of things. I think that one of the shibboleths that often is very important is to ask people what they've heard about it first, even, just to be able to say, you know, there's a connection here probably between the sorts of experiences you've had, between the sorts of experiences your child's had, and what is it that, and these feelings, these behaviors, the things that are sort of going on now, I wonder what you've heard about that. I wonder what you think might be the connection. To say we acknowledge it. There are lots of different ways of sort of looking at this. The most important thing is that by knowing it's there, there's something we can do about it. Also, the most important thing about it is that it means that this isn't something that we blame you for. It means that we know that people do the best they can under these sorts of circumstances. Our goal is to help you do more of what you'd like to be doing in the future. I think another thing that's been alluded to a lot is this question of a narrative and how growing up with violence, growing up with stress, especially in a multi-generational setting, leads people to have a narrative that often includes vulnerability, not worthy of love, guilt for not being able to fix things, not being able to love impaired caregivers, being damaged, and certainly an expectation for being punished for not being able to cope with any of this stuff or not being able to cope with sort of overwhelming emotions. And at least one of the things that we can do in our visits with families who have experienced trauma is to try to rewrite this narrative. And there are probably, two ways to do it. I mean, one is to explicitly say, when you hear these sorts of things, well, that's not really true, or to say, take opportunities to point out strengths, to take opportunities to point out how people have, in fact, tried very hard against odds, how people have succeeded in many ways. But a lot of it is by what you say, by what you do. It's really how you treat people, to show that you respect folks, to show that they are, in fact, just as worthy, if not more worthy, than all the other people that you take care of. And that over time, by demonstrating that, then the words that you use will take even more meaning. This idea that we can help people build emotional control is really important, and I think it's probably been one of the big advances in the last few years. I know there are people in this room who know a lot more about this than I do. In addition, some of this is also rediscovering some of the things that we've known about cognitive therapy or interpersonal therapy for a long time as well. But how can we help people to identify what the negative, what the triggers are for their negative feelings, for their difficult behaviors? Caregivers can often tell you what sets kids off. Young people can often tell you what sets them off or what sorts of reminders there are. You can often pick this up in your own visit because people, I think especially those 4+ ACEs folks that we've been talking about so much, will in fact change the subject or break off the conversation when you bring up some of these things which are triggers. They may not openly say that that's the thing that sets them off, but if you're watching carefully enough, you can often tell that that's what it is. So once you can name these sorts of situations, then you can help people to think about how they can either avoid them or minimize their reactions to them. And again, these are not situations where you have to come up with these answers. 99 times out of 100, people will have ideas of what they can do. You're really just helping them to structure something which they kind of intuitively knew they might be possible for them as well. How do we help kids self-regulate? I wish I could answer that. If I could answer it for myself, I would be really happy. But one of the things that is Actually, it's really interesting. As I read this list, I think I should put these on my refrigerator and remember for myself. So scaffolding, we all do best with a heads up. Anticipating and talking through day-to-day situations, rehearsing key behaviors and tasks. What are we going to do? Well, I mean, many of us get up every morning and look at blessed Outlook to try to remember what it is that we're going to have to do today. And we probably do some sort of mental sort of rehearsal of what some of those key things might be. So how can we help parents help kids do this? Needing extra time to stay organized and oriented. There clearly is a bell-shaped curve for this, so the very young need it, and as I rapidly approach dementia, I need it as well. So helping people to take that extra moment. It's really interesting that this is so similar to the idea of having a huddle and looking over your patient list at the beginning of a session to say, let's just take a breather. What are we facing this afternoon? How are we doing it together? How are we trying to mobilize our resources so that we all get out of here on time and we've done a good job and we're not going to go home and kill our families? Helping people read emotions in others and name them in themselves. I mean, we all want to reduce screen time, but maybe one of the best things about screen time could be sitting with your kids and saying, oh, that person looks angry, that person looks happy, I wonder why. Maybe there actually is a use for television. The mindfulness stuff starts with being aware of your own sort of internal feelings. So if we talk to kids and they or talk to parents and there's a situation, the situation sets me off, well, how do you know it's setting you off? I can start to feel my breath coming faster. Can start to feel my heart pounding. I can feel my palms get sweaty. I can sometimes tell even before it's happening, okay, well, when that happens, what can you do? One is grounding statements or just things that affirmations. I'm safe. This isn't really like what's going on. What was the Karate Kid's? The sky is blue, the sea is green. Just things that you can say to yourself that help you to sort of come back into control. Distraction and sanctioned alternative behavior. Distraction is very much underestimated and I think undervalued as a coping tool. Ideally it's not punching the Bobo doll because that might just be more arousing, but it's really okay if you to turn on some music, call a friend, have your own safe place for time out. Distractions are good. And relaxation or visualization, which can be taught to kids fairly easily, is another one. I will only talk about mindfulness very, very briefly because, as I said, there are people in the room who know tons more about it than I do, but it's this idea of building capacity to let thoughts come and go, experiencing mental relaxation so they can recognize it and learn how to reach it again. I think that one of the biggest challenges for those of us who live in a perpetually wound up world, and I think sadly that's probably many of us here, but certainly for kids who have experienced chronic stress, is that they actually don't know what it feels like to be relaxed. And it's really hard if you're practicing mindfulness or relaxation to know when you've gotten someplace without being able to sense that feeling. So biofeedback and some of those kind of enhanced techniques can help people to do that so that they can then start to pair the feeling with some objective outside measure. But sometimes the first thing you have to do, I find when I'm working with kids and trying to help them relax or trying to help them, learn some mindfulness stuff, at least the little, versions of it that I know, is to try to get them to see if there's any time in their experience where they can say, yeah, I did actually feel sort of relaxed or happy or calm or at ease, and then to have them try to describe what that felt like so you can say, well, okay, well, how could you get back there? What is it that you could do that would get you back to that place? One thing that I can do, because I often have the luxury of visits that are a lot longer than standard Peds visits, is this, practicing 10 minutes quietly, being aware of your breath, but there are other things you can do. I wanted to talk a little bit about referrals, because referring is a key part of sort of what we do. We really believe in collaborative care, but it's really a minefield when it comes to dealing with families who've experienced complex trauma. We need the team. We need other people to be working alongside us, but even the warm handoff is a huge challenge in these situations, or at least it can be. So one thing that I try to at least get into my own mind, and this is hard because I'm too old, is the idea that I'm not talking about referrals, I'm talking about new collaborative care plans. I'm talking about new ways of bringing other people into the team. I'm not talking about moving somebody someplace else. I want to emphasize the ongoing relationship. And obviously, any of you who are working in medical homes know this. I only do this with great care, and only after permission and discussion of choices and motivation. And I realize that sometimes my desire to refer people is a symptom of my own anxiety, that I've got somebody who I feel inadequate to help, and I think I need to get them to somebody who is better. But I need to have the faith that I can hold on to them long enough to get them there, rather than saying within the first 10 minutes of the visit, I think I know somebody who knows more about this than me. Describing in detail what will happen. And that's a challenge, because I think as someone mentioned before, especially for sort of mental health stuff, it's all kind of a black box. You're going to go off and see somebody. So being able to describe what it is that you're referring someone to. If you're going to send someone off for trauma-focused CBT, can you describe what that is? Can you actually say what the process might be? Who will be involved? How many sessions might it take? Obviously, it's fantastic if you can say, and my friend Barry does that, and he's really good at it. I've worked closely with him with other patients, and if I can, you'll like him. Another huge big piece is, before you go, secure consent to get information back. We all know that that's one of the biggest barriers in terms of working across collaborative lines with especially between primary care and mental health professionals. So just saying right from the get-go, from the family, is it okay if I call Jane to ask her, how this is going? Is it okay if we share information together, so that barrier is missing right off the bat? We've talked about some of the things that you can refer to. So because I know there are a lot of questions, I'm actually going to try to finish up a little bit early here. So I want to just sum up by saying that we've already made the case that complex trauma has an impact on lots of sort of different systems in people's heads. It changes the way they interact socially, it changes the way they think about themselves, it changes their mood regulation, it changes their cognitive abilities. And so if we're going to try to help people with these problems, we have to really try to target all of those sorts of brain systems at the same time. The relationships that we build with people, the narratives that we help them create, make a huge difference. The progress is likely to be slow, but it definitely happens, and I think you've learned a lot today about some of the techniques that can make it happen. We are urged to sort of suggest to you some things that you can maybe walk away with and change. So a couple of things that you could potentially think about in terms of your office practices. One would be for patients, what could you do that would just make simply the process of moving through the office less stressful for them and increase their sense of bonding with the practice? For yourself, what could you do that would actually reduce some of the multitasking demands or the sense of sort of chronic stress that's involved in the work that you're doing? And what kinds of self-care tools could you potentially put into place on a day-to-day basis that might help you to be more responsive to families when they come to you with these needs? What sorts of things can you do? And I put this under the rubric of provider mindfulness. it's sort of mindfulness about yourself, but in a sense, it's more mindfulness about the process of what's going on in caring for patients and families who have these complex problems. So one is there a way to have a huddle to anticipate and validate concerns about particular patients' needs? And what opportunities can you develop for supervision or support around these sorts of families? Opportunities when you might be able to just sort of sit down and talk about how easy or hard a particular situation was. And then in terms of some of the sort of interactive skills, is there any one thing that we've sort of talked about today that you might want to sort of take home and practice? And the one that always comes to mind is this asking permission thing, just to sort of try in your own little plan, do, study, act cycle to say, well, I'm going to really try to ask permission a lot in the next bunch of visits that I talk to, and last bunch of people I see, and just sort of see what happens, see how it changes the dynamic, and see if that doesn't perhaps make some things go better or differently. Lots of references, and these are all in the handout. These are just a few of our partners, so thank you so much. I'm going to end early as our MC back. Are you ready? Should I have kept talking?